In this episode of Beyond the Diagnosis, let me begin with a question that might feel uncomfortable. What if the way we practice medicine today is perfectly designed to manage disease but not prevent it? Two patients walk into clinic. Same age. Same diagnosis. Same lab values. One leaves with medication and a follow-up in 6 months. The other leaves with medication, a metabolic plan, nutrition counseling, a sleep assessment, and structured accountability. 5 years later, their outcomes look nothing alike. The difference was not intelligence. It was not luck. It was not genetics alone. It was intervention timing. We need to talk about timing. This week's healthcare conversations continue to highlight a familiar reality. Chronic disease is rising. Costs are escalating. Employers are demanding value. Patients are asking deeper questions. Yet many clinical systems are still structured around reactive visits rather than proactive strategies. As physicians, we were trained to diagnose and treat. We were not always trained to redesign trajectories. So here is the real question. Are we comfortable managing decline, or are we ready to prevent it? Functional and preventive medicine are not fringe concepts. They are structured approaches rooted in physiology. They ask us to look upstream. They ask why before what. Why is insulin resistance developing? Why is inflammation persistent? Why is sleep fragmented? Why is stress dysregulated? The answers often precede the diagnosis by years. The data is difficult to ignore. Most healthcare spending is allocated to chronic disease management. A large percentage of adults live with at least one chronic condition. Many live with more than one. Cardiometabolic disease remains a leading driver of morbidity and mortality. And yet, lifestyle modification remains underutilized as structured therapy. This is not about replacing pharmacology. It is about integrating strategy. Experts in this space have been saying the same thing for years. Treat systems, not silos. Measure earlier. Act sooner. Follow longitudinally. Address food quality, muscle mass, metabolic markers, sleep duration, and stress physiology with the same seriousness we apply to medication titration. But here is where it becomes personal. Early in my own advisory work, I assumed education alone would create change. I believed that if patients understood risk, they would automatically modify behavior. That assumption was wrong. Information without structure rarely produces transformation. Behavior change requires design. It requires follow-up. It requires clarity. It requires trust. It also requires humility. We must admit that 15-minute visits were not designed to reverse decades of metabolic decline. We must admit that handing someone a pamphlet is not a strategy. And we must admit that prevention requires systems, not slogans. So what does integration look like in real practice? It begins with earlier risk stratification. It continues with team-based care. It expands into digital monitoring. It includes measurable metrics such as fasting insulin, inflammatory markers, body composition trends, muscle strength, and patient-reported outcomes. It prioritizes sleep as much as lipid panels. It normalizes conversations about stress and social connection. And yes, it demands documentation discipline. There are legal considerations. Scope of practice must be respected. Informed consent must be clear. Coding must reflect services delivered. Ethical boundaries must remain firm. Prevention should never become over-testing. It should never become fear-based marketing. It should never compromise evidence standards. Professional integrity remains non-negotiable. Now let us address a common myth. Prevention is not profitable. That belief persists in some circles. Yet longitudinal engagement increases retention. Engaged patients return. Improved outcomes strengthen reputation. Value-based models reward prevention. The economics are shifting. Another myth. Patients will not change. That is only partially true. Patients do not change when they are overwhelmed. They change when they are supported. They change when they see small wins. They change when care feels collaborative rather than directive. The future of medicine will likely include earlier biomarker detection, digital monitoring, artificial intelligence-assisted risk stratification, employer-sponsored preventive contracts, and expanded telehealth engagement. But technology will not replace clinical judgment. It will amplify it. The deeper shift is cultural. Are we willing to move from disease managers to health strategists? If you are listening and feeling both inspired and skeptical, that is a healthy tension. Innovation in medicine requires both vision and scrutiny. We must protect evidence. We must protect patients. But we must also protect the future of our profession. So here is my challenge to you. What would change in your clinic tomorrow if prevention became your default lens? Would you screen earlier? Would you follow up sooner? Would you build a stronger team? Would you question whether current best practices are sufficient for long-term health span? I believe functional and preventive medicine are not about abandoning conventional care. They are about strengthening it. They are about respecting biology early instead of reacting late. We stand at an inflection point. You can continue managing downstream complications, or you can help redirect the current. If this conversation resonates, I want you to do 3 things. First, ask yourself what one upstream intervention you can implement this quarter. Second, leave a comment sharing one preventive strategy that has worked in your practice. Third, share this episode with a colleague who believes healthcare needs to evolve. Let us step into the conversation. Let us build knowledge. Let us challenge assumptions. Let us shape the next chapter of medicine together. Because prevention is not optional anymore. It is inevitable. This is beyond the diagnosis. And the future of medicine begins upstream.